All right, so now complications of mechanical ventilation. All right, so we're delivering this air into the chest. So here, there's a one port going in and one port going out, right? And again, it's assessing how much the tidal volume is for inspiration and how much the tidal volume is for exhalation. And we can look at that difference, and if that difference is really, really big, that means I'm losing some volume at the cuff, right? My cuff is blown, or there's a leak of some sort. So what kind of pressure alarms would I get on the ventilator if that's happening? You get a low pressure alarm, right? And I'm going to see on the ventilator that the volume that is set is not what I'm getting, and they can even tell you those two values. They say, oh, you're getting 400 in, and you're getting 200 back. Whereas the other 200 going, it's escaping out the mouth, and they're talking to you, right? They're rattling secretions, they're making noises, which they shouldn't, right? So we'll talk about long-term complications and long-term management, what we do for someone who's on a ventilator for a prolonged period of time, what the next steps are, and what can happen after day 1, day 2, day 3 of being on the ventilator. When we talked about intubation initially, we talked about the immediate complications like a pneumothorax or what else do we say? They can go through the trachea. They can cause all kinds of problems with the initial intubation. We can have esophageal intubation. There's someone who's established. They don't have complications day 0. Now we're on day 1, 2, 3, up to 7 to 21. All right, we're looking at these complications now. Okay, so first one that you always hear that we always have bundles for is called, is your VAPs here, right? Your ventilator-associated pneumonias. So VAPs are a hospital-acquired infection, an HAI, right? So a hospital-acquired infections. What's another example of a hospital-acquired infection? Something you develop in the hospital. C. diff, right? So C. diff over here, right? It's about 15% of our hospital-acquired infections. What's another one? CAUTI, right? It's 1%, right? But it's a huge deal. You see them come around, the infection prevention. It's like, oh, what did you get that Foley out? It is a problem. It's something to consider, but it is 1%. And when it does happen, it is serious. So we still got to do our bundled care for Foleys, right? We still do our bundled cares for what else? CLABSIs, right? CLABSIs are about 19%. Ventilator-associated pneumonia is about 31%. What's the most common one? That's your surgical site infections, right? So OR has their own package deals and bundles that they look at to make sure they're not getting infections over there. They do sponge counts, all kinds of things to make sure nothing happens, right? So that's how often it happens, but how deadly is it? It has the highest mortality. Ventilator-associated pneumonia has the highest mortality, right? 10%, which is pretty bad, right? Every 10 pneumonias that come from the ventilator, one of them dies, right? So VAPs are a problem. How do VAPs happen? I think on the next slide we go into more detail on that, but it's the leaking of what? It's microaspiration of secretions. So what the heck does that mean? So I got secretions that build up over the ET tube cuff, right? I got the cuff there at the bottom, and then those secretions are going to leak into the lungs, right? So how do we get those secretions out? Well, you can suction the ones that come from the lungs, right? That works. What else? Do endotracheal suction. That's the secretion from the lungs. What else can you do? Subglottal suctioning. And as we'll find out, the subglottal is actually the best one that reduces VAP. So we'll talk about VAP more on the next slide. All right, but ventilator-associated lung injury or ventilator-induced lung injury, VILI or VALI, right? These are a consideration when we have a patient on the ventilator. We're always looking to make sure the pips and plats aren't getting too high, right? We're always making sure that we have optimal PEEPs, so we're not getting atelectotrauma, okay? So, pips and plats should be under what number? Under 30, and we should have optimal tidal volumes. What's an optimal tidal volume? Good, 6 to 8 per kilo, right? Of ideal body weight, not their actual body weight, right? And then atelectotrauma. When you cause damage when you have atelectasis and you have caused trauma to the alveoli, this can start causing what? Causing the alveoli to get injured, right? And when they get injured, that creates inflammation, right? You got inflammation here. What happens when you have inflammation? Then white blood cells come in and they're like, hey, what's going on? Oh, I know how to fix this. I'm going to release all these little chemotaxins and all these other things, and that's going to start causing effusions and all kinds of other problems, right? And that's, just that one lung over there, but what about, if it's all the lungs, right? If your tidal volume is high, it's hitting all the alveoli, right? And that can cause a ARDS situation where we have all this infiltration of all these chemicals and fluid starts building up, And it wasn't the heart's fault, right? The heart wasn't pushing fluid back into the lungs. It was the lungs getting damaged by the ventilator itself. Okay, that's on top of their own pneumonia or their own aspiration pneumonia or something to that effect. Okay, so Platts greater than 30 can start causing damage to our alveoli. Tidal volumes that are too high, especially greater than 8 per kilo, that's going to start causing damage to our lungs. Okay, and if your PEEP is too low, right? How much PEEP do you want? Enough PEEP, right? You want ideal PEEP. You don't want, you can bring the PEEP up as long as your pressures tolerate it, but you don't want to bring it down too low, right? Because that difference of inflating the lungs completely and then deflate them completely can start damaging. It can, it starts causing more atelectasis and more trauma to your alveoli. Okay, so low PEEP is just as bad as not having any PEEP, or it's like you just keep everybody at 5 a PEEP. That can be just as bad, right? You want to make sure the PEEP is matching your peak pressures, right? And that's what we call the driving pressure. Okay, so if you have all this damage, if it doesn't cause a irritation of the lungs and inflammation of the lungs, what's the other problem that can happen? If you have too high PIPs and Platts and too high tidal volumes, they just straight up pop, right? That's called a pneumothorax, right? And the air starts leaking, and then that causes, it might be a little 10%, or it might be the whole lung that gets deflated. Okay, and then PEEPs, right? These, we say, oh, maybe too high of a PEEP, that's going to cause some barotrauma. PEEPs, it's impossible for PEEPs to cause barotrauma unless you go higher than 24, 26 PEEP, right? That's not what's causing it. It's the tidal volume on top of the PEEP that's causing the damage. So that's why we choose ideal tidal volumes. That's where we have other strategies to improve someone's oxygenation, okay, that we talked about last time. Okay, suboptimal PEEP, though, that does cause damage, right? But PEEP itself is not, when it's getting higher and higher and higher, is not the one that's causing the damage. I think we touched base on this on the next slide as well. All right, so what else can happen when you're on prolonged ventilation, more than 3 weeks for sure? That's going to lead, you're definitely at risk for stress ulcer disease, right? Or peptic ulcer disease. And what happens when you're on the ventilator for more than 3 weeks? You see someone's on the ventilator for 21 days or more, they have a 52% mortality, which is crazy, right? It's a flip of a coin whether they're going to live or not. And they might make it out of the hospital, but this is at 1 year, right? So 1 year, are they going to survive, right? That goes a little bit less, like at 2 weeks, a little bit less at 1 week, but definitely at 3 weeks, they've tracked the patients. They found that that is the mortality for these patients. So we want to get patients off the ventilator as soon as possible, right? So yeah, so going back to stress ulcer prophylaxis, because someone that's on the ventilator that gets a massive GI bleed on top of their ARDS, on top of their liver hepatic encephalopathy, on top of their colon that's ruptured, on top of their AKI, all these things, you're just adding another GI bleed on top of that. That's a problem, right? So when you're on the ventilator, that puts a lot of stress on the body, right? Being in the ICU puts stress in the body, and that causes stress response, causes cortisol to be released. Cortisol makes more hydrochloric acid being produced by the stomach, and it also decreases gastric blood flow to the stomach. So when you're in a stress state, you start clamping down things, right? You clamp down to your skin, you clamp down to your GI tract, and now your GI tract can't wash away the hydrochloric acid that you've overproduced, right? So it just stays there and it eats away at the gastric lining, okay? And you might think like, oh, I was in nursing school, I got stress ulcers. It wasn't, it's when you're in the ICU, that is stressful, right? Nursing school might have felt like ICU though. All right, so mucosal ulcerations, if they already have it, they're higher risk too. And we'll talk about this more in GI, about PUD prophylaxis. Basically, you're on one of these two meds. You're either on a PUD, you're either on a PPI or an H2RA. So these are the two medications that we give for, one of the two medications we give for preventing GI bleeds, right? And then we got this other fancy term here, all right? Try to say it 3 times fast, critical care polymyoneuropathy, right? That's a critical care associated illness. So it's being in the ICU causes a lot of your muscles to pathy, to die away, right? It causes your muscles to start deteriorating over time, right? Just within 18 hours, you start getting deterioration of your muscles. If you're 35 years old, it might be at 3%. If you are, 53 years old, it might be at 10%. If you're 80 years old, it's like 17 to 20% of your muscle mass is getting eaten away every day, okay? So how do you prevent that? Well, it's caused by bed rest-itis, right? So if you're a bed rest for too long, right? You have some older providers, they're just like, oh, just let them rest. Let's let the bowels rest. Let's let them rest. Don't get them out of bed. That's not good. So it, in of itself can cause VTE, causing thromboembolisms, but also the mobility itself causes delirium. It causes more days in the ventilator. There's all kinds of research that shows how good it is to mobilize someone. And if you don't mobilize someone, they are going to develop this ICU acquired weakness or bed rest-itis, or if you're fancy, critical care polyneuromyopathy, right? So, or CINM. These are the things that can develop for patients been on bed rest for a long period of time. Like our friend down the hall, at the end of the hall, right? She's been here, what, 14 days, 20 days, right? And they're like, oh, she has myasthenia gravis. No, she's been on the ventilator for 20 days. That might be the reason why she's not getting on the ventilator, right? So how do we support that? We get PT involved to help move the patient. We start moving them and escalating them up our progressive mobility scale, which we'll talk about as far as our ICU liberation to get patients out of the ICU and off the ventilator. We have the ABCDEF bundle. E stands for early mobility. All right, so each day of prolonged ventilation decreases your weaning efforts. Like for today, she does great, and she's like, oh, look at that, she get 400 volumes, pressure support of 8. Let's let her rest. Let's try to get tomorrow. It's like that we're gonna lose more muscle tomorrow. We need it. Today's the day. That's the time to start. Okay, and then swallowing dysfunction. Having a tube in your throat for a long period of time is going to impair the gag reflex. And you got them off the tube, and they're like, I want apple pie. And now the apple pie is in their lungs because then they don't really remember how to swallow, or it's at the back of their throat, and they can easily aspirate. Okay, so they're a high aspiration risk. So back in the before the year 2000, their tidal volumes were like 10 to 12 per kilo. They're doing like 800, 1200 tidal volumes, and that caused actual lung contusion. This patient obviously did not survive. So this patient's lungs, they are all bruised and they are damaged from that trauma because our tidal volumes were greater than 8 per kilo. Okay, and then so you got VILI here that we just talked about. It's some of our complications. Right, we have mechanical problems just due to the ET tube being there. Right, the ET tube itself can eat away at the mucosa. It can cause more damage, and we'll talk about that coming up. You can have complications related to oxygen. How does oxygen cause problems? Yes, too much oxygen, hyperoxia, or hyperoxygenation causes free radicals to form. And free radicals also contributes to this ARDS process, which is not helping the situation. Okay, and then we have VAPs. I think we're going to talk about that on the next slide, right? So VAPs can be developed with someone on the ventilator the more time you're on the ventilator. Okay, and VAPs are defined as more than 48 hours on the ventilator, and you get a pneumonia, that might be a ventilator-associated pneumonia. So if you get them off the ventilator within 2 days, it's like, oh, no, can't say it's a VAP, right? So there's that too. Okay, and of course that lung injury can cause some pneumothorax. Right? All that air in the lung over there compared to the lung on the right, which has nice tissue. The other lung is all full of air. Air is black, pure black on X-ray or CT, right? Whereas the other lung had some black in it, but you can see the tissue in there as well. Okay, so those are our complications of being on the ventilator. All right, so ventilator-induced lung injury. So we kind of mentioned that we want our tidal volume to be good. You want your peak pressures and plateau pressures to be good. And what is a good PIP and plat? Less than 30, right? Optimal tidal volume is really 6 to 8, right? And then 4 to 6 if you're an ARDS, but we can get all the way down to 4 to prevent that volutrauma, okay? And then optimal PEEP, right? So the PEEP needs to be good. Otherwise, if it's too low, you can also cause damage. So if we look down here, we have suboptimal PEEP, right? We got a PEEP like a 5 right there. We got a PEEP of 5 right here, let's say. Okay, and we gave too much volume. Oh, shoot, now that too much volume on top of that 5 a PEEP causes peak pressure of 40, 45. It causes a pneumothorax or damage to my lungs right here, right? Damage to my lungs, and they start leaking. I got interleukins and chemicals that cause inflammation, which is not good. So that's PEEP of 5 and tidal volume is too high. But what if the PEEP is 5 and tidal volume is great? It's like 5 per kilo. It's like, look at that. Look at my tidal volume. I measured the ideal body weight. I got how tall they are. And look at that beautiful tidal volume. But the PEEP was suboptimal. You weren't opening up the alveoli enough, right? You want to open up the alveoli. You want to have PEEP that is optimal, right? There's too much PEEP. That's where you have too much tidal volume on top of your PEEP, right? But you don't want too little. Otherwise, that can cause atelectasis. Okay, and then what about you have this difference here between the high and the low? Like we can say go all the way to 40 there. That big difference from high to low can cause a atelectotrauma, cause trauma to our alveoli because it's like open your car door all the way and then slamming it shut to Alex's point where it slams all the way, and then you have to work really, really hard to open that up again and fill it all the way up, and then you let it slam all the way down again, right? That opening and closing, that big difference between the high number and the low number is your driving pressure, right? And that should be less than 15, right? So here we got a PEEP of 15, right? So we go, okay, I learned to have higher PEEPs, high PEEP of 15, but they're still, they're still hitting that high zone with the tidal volumes. So optimal is to have this nice driving pressure here of 15, the difference be 15, have a good PEEP, have a good tidal volume. So those are all the things we're looking at to make sure we're avoiding ventilator-induced lung injury. Okay, and we could make all those things happen, but then they can get biotrauma just from the like high FiO2, for instance, or they have all this damage from the above can start causing the inflammation to happen and cause the infiltration of white blood cells and infiltration of those immune processes and cause multi-system organ failure, right? Cause multi-organ dysfunction syndrome, MODS. We learned about that with sepsis, right? The end result of sepsis with that widespread inflammation can lead to ARDS, the lungs shutting down, the kidney shutting down, mitochondria shutting down, but also it happens with just being on the ventilator, right? And not keeping the volumes adequate. Okay, so to make sure that make sure the FiO2 is good, make sure our volume and pressures are good, making sure we're fixing any kind of infection that might be there, making sure they're optimally recovered, and then hopefully we can optimize them to get them off the ventilator. Okay, and then also we talked about this atelectotrauma and volutrauma can happen when our alveoli are misaligned. Our alveoli look like the one down here. That's weird. It has to go in and has to make a little U-turn to come back up and inflate those lungs. And how do we fix that? Especially with a sick patient, you can prone them. That's going to give optimal delivery to alveoli. It's going to open up more alveoli too and help out. Okay, so that's the idea behind our to avoid VILI, right? We make sure the PEEP is not too low, right? That causes atelectotrauma. Make sure we're tidal volume is not too high. That's going to cause volutrauma. Make sure we're in the sweet spot right here. Okay, make sure we're delivering the breath, and when the breath comes down, the breath is delivered, it comes down. It's not hitting the high zone, and it's not getting too low. Okay. So VAPs, ventilator-associated pneumonias. So what is VAP? It's when you get a pneumonia, a hospital-acquired one, because you could get hospital-acquired pneumonias without a ventilator, right? That's possible. When you get patients RRT'd from the floor after 5 days, it's like, that might be hospital-acquired pneumonia. Or it could be a hospital-acquired central line infection or a hospital-acquired CODI, right? Or they could have had surgery 5 days ago. It could be a surgical site infection. So we look at these things, right? It takes infection about 2 to 3 days at the minimum to start developing, right? So if you develop like a fever the next day after intubation, they probably came in with that. It wasn't the ventilator that caused it. So we say 48 hours, right? That's when they start getting pneumonia symptoms. After 48 hours, that's a symptom and they're on the ventilator. It could be ventilator-associated pneumonia. Is it? It's not very common, but we do all the things to prevent it if we can. Okay, so how do we know that we didn't cause it? You got to swab them, right? We do a sputum culture, right? So when they first get intubated, right, put on a ventilator, we do a sputum culture. If that sputum culture shows like pneumonia organisms, there wasn't the ventilator that caused it initially, right? But if they develop, 5 days later, you had a initial sputum culture was negative, and 5 days later you do a sputum culture because they're showing signs of pneumonia and it shows something growing, that's our fault, right? Because it was negative when we tubed them, there was nothing growing in the lungs, but then 5 days later something's growing. Then that is our fault that we have to own. Okay? So what are symptoms of pneumonia? How do you know someone has a pneumonia in front of you? No one's doing it right now. No one's coughing up purulent sputum, which is good, right? But that is a symptom, right? Coughing up, and why are they coughing? Because their lungs are irritated from the sputum, okay? So all that sputum is happening. They got new secretions developing. They got a change in color of the secretions, right? It's no longer clear. It's starting to turn green, or it's just Pseudomonas. So they start turning, like brown, right? Which is usually like a fungus or mold. So they start developing these changes in their sputum color or sputum amount, right? Like, dang, that guy's juicy. Look at all that sputum getting out. It's like, right? RTs love that noise. They go to sleep with that with their white noise at night, right? Google, play play sputum. Okay, 10-hour YouTube sputum. Anyways, so you have the sputum change, increased sputum. You have increased changes in color. They got O2 requirements are increasing because all that sputum is filling up the lung, right? You might get some rise in your pips and plats because that pneumonia is getting worse, right? And of course, they have signs of inflammation. That's your SNS firing off. They can start getting tachycardic. They start getting tachypnic. They start getting inflammation symptoms, which are fever, right? They can't really tell you they have malaise and fatigue and such, but you can see a fever, or you can measure a fever. You can't really see it, can you? Anyways, so yeah, you can measure a fever and say, oh, they're getting they're febrile. Why are they febrile? It could be a pneumonia, or it could be due to a drug that we introduced. It could be due to just atelectasis, right? Atelectasis itself can cause fever. So if we improve the volumes, improve the PEEP, and it goes away, well, maybe that it was just atelectasis. It wasn't a pneumonia that's developing. So we kind of mentioned this, but how does a VAP develop? It's due to all the secretions above the cuff of the ET tube, right? The ET tube cuff should be inflated, 1, so that the secretions don't get down there, and 2, so we can give the volumes we want to. But those secretions can microaspirate into the lungs here, right? So this microaspiration of secretions in the lungs is what causes VAPs. So how do you stop that? How do you prevent that? We can do ET tube suction, where we come in, right, and we play our little white noise, and we're we're going to suction all of those secretions out of the lungs that got there in the first place. But you know what's better is to take these secretions out also, right? So that's called what kind of suctioning? Subglottal, because the glottis is what? That's this structure right here above your vocal cords. So subglottal, you introduce a little catheter all the way in there, and you suck up all the secretions above the cuff. How often do you do that? Q6, right? Oftentimes we find the subglottal suction catheters like in drawers. We find it, you got carpool with them to work, you open a glove box, what's all this, right? It's like all their parking tickets, and it's also subglottal suction kits, right? So those are the best thing to improve someone's outcomes and to prevent a VAP is doing subglottal suction. ET tube suction is good, but it's subglottal, it has the best evidence and the most efficacy of reducing VAPs.
So you would do both?
You do, yeah, so Q2 on the ET tube suction, Q6 on the subglottal suction. And what else do we do to prevent VAPs?
Oral care.
Oral care, right? Because these secretions that make it into the lungs right here, you want those to be the best secretions ever. You want to write to grandma about these secretions. These these secretions have been decontaminated with hydrogen peroxide and what's it called now? Some CPC now. We kind of phased out chlorhexidine recently, so it has CPC. I do that once a shift, grandma, and then every 2 hours, 2 hours, I'm alternating with alcohol-free and peroxamint. These are the best secretions ever. You're going to want to see these, right? So then, if they do get down there, they're not going to cause disease. Okay. So should you turn your patient before or after suctioning? Or should you suction before or after turning?
You should suction before moving them.
Before moving them, because that cuff, it does not create a huge seal. It's not it's not like a Berlin Wall, right? It's like and then it's done, and we're going to take it away like braces, right? Or it's just a cuff, right? It's just a little balloon in there, and it can move around. So when we turn them to the side, we don't want to have all the secretions leak down into their lungs, right? We want to make sure that we are suctioning before we turn. Okay, so your contaminated secretions, we can decontaminate them by doing oral care, and we can suction those secretions that do make it past the ET tube by getting those out. A, by suctioning them out, but also B, when you suction them, it makes them cough. So it gets the secretions to the base of the lungs, right? Because your catheter doesn't go that far. It only goes to the carina. That's why they're coughing. Okay, and how do you fix a VAP? You do antibiotics, right? So if you identify they have a VAP, they develop infiltrates on chest x-ray, they have that fever happening, they got increased secretions, they got green secretions instead of clear secretions now, they're starting to develop a ventilator-associated pneumonia, right? So we can give medications that cover bugs that you get in the hospital. What kind of bugs do you get in the hospital? not bed bugs. That's no, don't get bed bugs, please.
Pseudomonas.
Pseudomonas, right? So Pseudomonas is to grab negative bacteria, and only certain antibiotics cover it. And here's Pseudomonas on our little chart here, and these are the antibiotics that cover it. So we got this guy right here, gent and tobramycin. They cause a lot of complications. We don't usually give those ones. We have what else do we have? We have our ceftazidime and cefepime will cover it. Piptaz or piperacillin tazobactam, otherwise known as Zosyn. That's why almost everybody in the ICU who has pneumonia, it's like, oh, let's try Zosyn, right? So just in case they get Pseudomonas, right? And then what else? You got your big heavy hitter, meropenem, right? So meropenem is your heavy hitter that will also cover Pseudomonas, okay? And then another bug that you get in the hospital setting is what? Besides Pseudomonas? MRSA, right? So they could develop in the hospital, they could develop in the ICU, right? They're high risk for MRSA. Everyone that comes in the ICU that gets what welcome present to figure out if they have MRSA or not. You get a little nasal swab, right? So a little nasal swab to see if there's MRSA there. If there's MRSA in the nose, it might be in the sputum. Okay, so we can, if that MRSA is positive, we can give something like vancomycin. So we look at our chart over here, we find vanco, right? Sorry, we find MRSA, and you'll see that vancomycin checks that box right there. There's vanco, right? We also have, tigacycline. We don't. That's very rare. That's for a really serious infection. But vanco is a good one. Linezolid's a good one. These are different ones we can use to cover for vanco. Okay, fluoroquinolones are not great medications. They cause all kinds of problems. We'll talk about that more when we talk about infectious disease and our antibiotics. Okay, so VAPs again are not very common, but we still have to be on high alert for them because they have the highest mortality out of any hospital-acquired infection. Okay, so how do you prevent it? Like we mentioned, how do you get a ventilator-assisted pneumonia? You get a ventilator, right? That's the only way you get it. So if you don't get someone on a ventilator, it's impossible to get a VAP, right? So if you can avoid it in the first place, then that's great, right? How do you avoid getting ventilated? Don't get tubed, right? You watch out for those nurses or RTs and providers. But what else? How else can you prevent it?
Avoid sedation.
What's that? Avoid sedation? That's usually when they're on the ventilator already. You can give, NIPPV. What is NIPPV?
Oh, non-invasive.
Non-invasive positive pressure ventilation. So you can do CPAP or BiPAP therapy. You can do, vapotherm therapy or heated high flow nasal insufflation device. You can use all these things to help prevent them getting on the ventilator, right? But if they are on the ventilator, and so you want to take it out real soon, right? Of course, when they have passed these trials, right? A spontaneous awakening trial or a spontaneous breathing trial on a weaning mode, we assess, are they good to come off? And then now it's great, right? Now we could say, oh, let's take it off. Take it off within 2 days, that's even better, right? Or you get it off as soon as possible, right? We always look at the parameters every day to see if it's good to come off the ventilator. Okay, we bundle care, right? We do have our, we have our ABCDF bundle, which is for getting patients off the ventilator, and then we have our VAP bundle, which is for patients to prevent patients from getting a VAP in the first place, right? So subglottic we mentioned, that's in yellow, has the best evidence here. So best evidence is in yellow, or sorry, green is the best evidence, but subglottic is Q6 hours is going to help prevent that VAP from microaspirating, right? That secretion from microaspirating into the lungs. Head bed 30 degrees, there's really no evidence it works, but sure, go for it. It's not going to hurt, right? You can do it. It doesn't cause harm, but it actually doesn't do anything. But so if it's like, that's why if you look at every room right now, every nurse promises and pinky promises and writes a will and trust that their bed 100% is 30 degrees. You're going to find a lot of beds that are not 30 degrees right now, right? So and that's across every ICU, not just Palmdale's ICU. So that's so we would have a lot more complications if 30 degrees was causing VAPs, right? And oftentimes you have like spinal patients where they keep them like 10 degrees. It's like, I don't know, but what about the VAP? It's with a grain of salt. Yeah, it can help, but it's not going to be our one and only thing. If you had to choose like 5 interventions to do, you would 100% be doing subglottal suctioning or get them off the ventilator if you can.
Gravity.
Yeah, so the idea is that they would aspirate. So they have all this nausea and vomiting, all this increased gastric contents, then that would cause, they're high risk for aspiration. Or the secretions would make their way up into the oropharynx and then make their way down into the lungs. Okay, but we have like a cardiac sphincter here. We have, esophagus can help prevent that too. All right, and then the cuff pressure is also there. That cuff is going to help prevent any kind of aspirate to happen, and we do subglottal suctioning to take out any secretions that might develop. Okay, and then what else? We can prevent colonization of the lungs to begin with. So the oral care, make sure we get these those secretions to be the best secretions ever. Now we're using CPC. It's chloral peptidyl something citrator. I don't know, I forget what it stands for, but CPC has been replaced CHG. CHG only really had evidence when you did it with cardiac surgery patients. And unfortunately, we do have cardiac surgery patients, so I'm not sure why they changed from CHG right now. But yeah, so CHG, really the only evidence they found was for cardiac surgery patients. And it wasn't the best evidence. It's just like, oh, that's nice, right? So, but it is something we can do to help prevent VAPs. We're going to do all the things we can do to, to stop anything from developing. Okay, and then suctioning. So we do endotracheal suctioning and we do subglottic suctioning, right? And the oral care, that kind of involves suctioning too. How often you do oral care? Q2 hours, right? And then we do some things that are just that it sounds good, or not that it sounds good, but to say, hey, since you're going to suction, why don't you give Protonics too? It's like, how's that going to prevent a VAP? All right, so, but they kind of bundle it up, it kind of like got piggybacked on there. It's a little stowaway with the VAP bundle now. So we just do PUD and VT prophylaxis, just kind of attached to VAP. So PUD prophylaxis, how do you prevent it? You give a PPI. What's an example of a PPI? Is Protonics or pantoprazole. If it ends in prazole, it is a PPI. And if it ends in what, is it a H2RA? Tadine, right? So yeah, famotidine, there's cimetidine, there's other different tadines. Those are ones that we could give to prevent H. pylori from developing and prevent a ulcer from developing. And then we have just because we have VT prophylaxis, right? So VT prophylaxis is preventing a venous thromboembolism, all right? And we give pharmacological or RX and mechanical. So we do mechanico-prophylaxis and pharmacoco-prophylaxis. Say that one 3 times fast, all right? So we give medications and we give squeezers, right? So you put SCDs in place and that's going to prevent, it's going to mimic walking. So anybody who's on bed rest should have SCDs in place, right? And then, because there's really no contraindication in that except for what? Amputation. They have no leg. It's not gonna work, right? What else? They have a cellulitis, a really like an open wound. Probably not great. It's like, we got to squeeze them, right? That's not going to be the best outcomes, right? The manufacturer says DVTs, but that was old literature. You can use it for DVTs, but it might be frowned upon until you get everybody on the same page. But because the best way to prevent DVTs is to walk, right? And SCDs simulate walking. But if it's causing a lot of pain and it's causing, yeah, you're not going to squeeze it, okay? And so we got VT prophylaxis with the mechanical SCDs, and then we have pharmacological. So what kind of meds can you give to stop someone from developing a clot? You give an anticoagulant or antiplatelet? An anticoagulant. An antiplatelet is like aspirin or clopidogrel or those guys, right? Whereas a anticoagulant stops the further development of a clot, right? So antiplatelets just stop a clot from being made initially, right? So when they have little small coronaries, we don't want those coronaries to get clot immediately, right? So Lovenox or heparin are usually our go-to agents, okay? Heparin in renal failure, okay? Lovenox will build up too much in renal failure. All right, what else? We have other gear we can give to prevent VAPs, such as like a antibacterial ET tube that's coated in silver, right? So Blade comes in, it's like, watch out, all right, you got a silver ET tube, right? And then, but they found that there's really no evidence that actually works. But you buy your washing machines, it has like, now with silver, now with AG, silver. It's like, okay, cool, I guess I'll pay extra $500 for that, right? But yeah, so it didn't really work here. I'm not sure, I don't think it works in real life either. But either way, there's those things. We have ET tubes that have suction catheters attached to the little port at the top there. If you go back to the ET tube section, it has a little extra suction port for actual like continuous subglottal suctioning, which has great evidence. But they're like $20 a piece, and whereas a regular ET tube is like $1.50. So it's like, well, are we going to tube everybody? How do we know everybody's going to the ICU? It's like, well, just stock in the ER and stock it in ICU, and we'll make sure we have that subglottal suctioning continuously, right? So that's something we're working on. And then what else? So other things to prevent VAPs is prevent the stagnant secretions from getting into my mouth and down into my lungs. So when you see an ET tube or a ventilator circuit like this, where it's upright, or all this condensation and such is going to make its way down to the patient, and it's going to cause a VAP, right? So we don't want that. The vent circuit itself, right, could harbor bacteria, so that gets changed. is usually every 7 days and PRN, right? PRN being soiled. The HME, what's an HME? HME is this guy right here, right? The little cardboard thing that heats and humidifies the air going into the patient. That thing can get clogged up, and that can then percolate and bacteria can form. Okay, so that's the idea behind doing to prevent VAPs. Another thing we could do initially when we intubate someone, we put one tube we intubate the trachea, we intubate the urethra, and we intubate what else?
Oh, the OG.
Yeah, we put a tube in intubate the stomach, right? So the esophagus. So how do we intubate the esophagus? With an oral gastric tube, not a nasogastric tube, because what does your nose do? Your nose is just a fancy HME, right? It heats and humidifies the oxygen or the air coming into our lungs, right? And it also traps a lot of particulates and bacteria and flies and gnats and other things that might get into your lungs, right? So it looks like this, right? So why an OG tube? Because your filter is ugly, right? You don't want that to then be inoculated into your lungs, okay? So that's the idea to prevent VAP and the evidence behind it. Okay, so then what about injury to your lungs after having been vented for a period of time? And usually after day 8, we consider trachs, right? So sometimes a trach itself can cause complications too, because it's in there for a long period of time, right? So if the ET tube is through these cords for a long period of time, it can cause laryngeal injury, where it damages the larynx and damages the vocal cords. They have vocal cord hypoplasia and vocal cord atrophy, and they have a voice that is very what? Hoarse, right? They have a very hoarse voice. So they have, they're very, very quiet, or they can't speak that well, right? And often we often also mention that it can impair the gag reflex as well. So getting a speech eval is good for someone that's been on the ventilator for more than 5 to 7 days. All right, you can cause tracheal injury with the cuff being inflated. So this cuff is inflated right here. We said it's not causing a perfect, nice concrete seal inside the trachea. And we don't want it pushing up against the trachea a lot, because then it's going to start impairing blood flow there. And then the tissue gets necrotic, and then it starts creating fistulas between the trachea and the esophagus, for instance, right? So we want to avoid the cuff pressure from being too high. And what is too high? 30 is kind of our RT kind of number, right? So less than 30 is good. So 20 to 30 millimeters of mercury is where you want the cuff pressure to be. And the RTs check it, I think, twice a shift or once a shift. They'll check to make sure the cuff pressure is less than 30. Okay. Otherwise, it can start causing damage to the trachea, and also just moving back and forth, what can cause a damage to our trachea here. So you can see here we get a fistula, a tracheo-esophageal fistula. So this balloon was overinflated. It was greater than how many points? Greater than 30 points, and it started causing erosion into the esophagus. And that is not easily recoverable. It's almost like a 60 to 70% mortality. It's a huge deal when that happens, right? Because then you have to stent it. There's all kinds of things to consider when that happens. Okay. So then what else can happen? You can damage the carina when you do multiple ET tube passes. That's why we only limit it every 2 hours, instead of when they're on a trach, maybe every 4 hours. But we want to get the secretions out if they're there. But if they're not there, we don't want to start causing damage to the carina or causing damage to the bronchi. And then just being vented for a long period of time, especially with secretions, those can start causing deformation of the bronchus. The bronchus gets deformed and gets weakened muscles and atrophied muscles on the outer rings. So the bronchi, when they inhale, you push all the air in, it's perfectly fine. But when they exhale, these lungs collapse, right? Or not the lungs, but the bronchi collapse, or the trachea can collapse, and that causes air trapping, causes air hunger, increased work of breathing, makes it difficult for them to get off the ventilator or even to stay off the ventilator, right? So usually when you extubate someone that's been on the ventilator for 7 days, they have a high chance of being reintubated for this malacia issue, this tracheomalacia or this bronchial malacia, where the bronchus or the trachea get weak. And how do they know this happens? They intubated dogs for 21 days, 3 months, and kept them intubated for that long. Hey, look what happened. It got it went away. And look at this one. It ate away through that trachea when we had the pressure too high. All right, so that's animal testing, which is a little unethical. right? But they do that also with like head injuries. Like head injury patients, they say, you know, I know this happens to this head injury patient because I hit a monkey with a ball at 20 miles per hour and 50 miles per hour, and look at the head injury pattern. Look at that, isn't that cool? And it's, yeah, we're gonna get an FBI watch on you. It's not gonna sound like a serial killer. So yeah, so there's some things we do learn from evidence which can be unethical. All right, so we have a tracheoesophageal fistula. We also have a trachea-innominate artery fistula. This has like a 95% mortality. It's ridiculous. You have the brachiocephalic artery that comes out the first branch off your aorta, and it kind of makes a little turn right here to brachiocephalic, goes right over the trachea right there, right? So if we look at it from another point of view, the balloon can eat through and eat into that artery, which is not great, right? So that's really, really high mortality. So here's another like stick figure view. So you can see the first branch is right next to the trachea. And that's kind of the danger when you do a tracheostomy at the bedside, especially. They got to make sure they go high enough, right, to make sure they don't go through an artery. Okay, it's like when you do a crike on TV, all right, you got to make sure you find the right cartilage, otherwise you just cut through an artery. Okay, so that's the idea. That's what can happen with someone that has a trach for too long or a ET tube for too long.